So what we did in the biomarker analysis for the CheckMate 649 Nivo-Ipi versus chemotherapy study is look at the baseline archival samples from patients who enrolled in the study. This is the largest cohort prospectively that looked at these biomarkers in a large Phase III study in this disease. So approximately 50% of the patients had sufficient tissue to provide tumor and baseline blood samples for whole exome analysis for matched tumor and blood analysis, and bulk RNA-seq, looking at gene expression signatures that would shed light on important effector cells and processes that happen in the tumor and the microenvironment that may help us explain the outcomes with these treatments. So what we did, we got baseline samples and we analyzed them for MSI status, looking at by using PCR analysis, and that status was available in close to 90% of patients. And we also looked at gene expression signatures and whole exome, and that samples were available in approximately 50% of patients. What we noticed that, not surprisingly, MSI high patients favored and really benefited from Nivo-Ipi. Median OS was not reached. The hazard ratio was 0.29 for survival, highlighting the importance of biomarker testing in that population. What's interesting is 6% of the population had TMB high tumors, and of those patients, 16 out of 21 TMB high patients were also MSI high, so that's not surprising. Those patients benefited as well. Then looking at gene expression signatures, we looked at all the usual suspects, things that you would expect, such as inflammation, angiogenesis, stromal fibroblast factors, and of course the Treg signature, because that's associated with immune modulation with Ipilimumab. So not surprisingly, we found that high inflammation signature, so we divided these analyses into tertiles. So we looked at high, intermediate, and low tertiles. And the highest tertile in the inflammation signatures across all inflammation signatures clearly benefited from Nivo-Ipi compared to chemotherapy. Then looking at the stromal signature, having low stromal signature, so less of the fibroblast presence, was also beneficial for Nivo-Ipi, suggesting that fibroblasts perhaps have immune suppressive phenomenon associated. And then we looked at angiogenesis and epithelial proliferation. Having low epithelial proliferation, so low angiogenesis signature, was also favorable for Nivo-Ipi outcomes. And lastly, we looked at Treg signature, which is having high Treg signature was predictive of improved outcome with Nivo-Ipi. You could say, well, high Treg signature can be also confounded by inflammatory signature because Treg has come together with other effector T cells. So we controlled for that. We looked at Treg signature independent inflammation in multivariate analysis, and that looked like independent predictor irrespective of inflammatory signature. So that was very important to see. And also high proliferation in general, proliferation probably in the tumor more so than anything else, was also predictive of better outcome with Nivo-Ipi. So this was an important step forward. We're so thankful to our patients and their caretakers for their trust in providing these samples, and certainly it was a multi-center, really important test to be able to do in a prospective Phase III study. And in summary, what we saw is that, not surprisingly, MSI high and TMB patients benefited from Nivo-Ipi more than chemotherapy. Patients with high Treg signature in their tumor, high proliferation, high inflammatory signature benefited, and then conversely, low fibroblast, low stromal, and low angiogenesis signature benefited from Nivo-Ipi compared to chemotherapy. How do we take this forward to the clinic? We need to validate it in a prospective fashion. Having bulk RNA-seq in the clinical trial is certainly great, but we need to come up with other modalities to be able to do it in real time if we're really going to bringing this to the clinic.